There's been a lot of recent interest in arthritis of the CMC joint of the thumb, from simple debridement of the entire trapezium and pinning to arthroscopic techniques. Potential advantage of arthroscopic techniques are that you preserve, for the most part, most of the patient's normal anatomy, and we'll discuss if that is a potential advantage to the patient. Prior studies have included those by the late J. Menon, who initially reported in '98 debridement and interposition with various materials, including mainly Gore-Tex. Gore-Tex did not do as well as the palmaris or the fascia lata patients, but this was one of the earliest reports of arthritis. Dr. Menon reported on about 25 patients that had fairly good pain relief in 3/4 of the patient, but some patients required a second procedure due to the removal of the Gore-Tex. Randy Culp and Mark Recant at the Philadelphia Hand Center reported on using the smaller arthroscope, the 1.9 arthroscope, and a 2 mm shaver, and also shrinking the surrounding ligaments, AOL ligament in particular, with debridement and removal of 1/2 of the trapezium. We reported our initial technique with Dr. Adams, Berger, and myself in 2005. Alex Bedia also reported a very similar technique using a biodegradable polymer as an interposition material. The technique that we use is to use a pneumatic tourniquet, vertically suspend only the thumb with about 5 to 8 pounds of traction. Fluoroscopy is very helpful to identify the CMC joint and to be sure you're not a member of the wrong joint club. It's very easy to get into the ST joint, particularly in the arthritic patient, and a needle with the fluoroscopy can make this quite easy. We tend not to need to use insufflation of the joint, although that is an option. And initially, a careful incision vertically of only the skin, and careful spreading down to the joint to avoid contacts with branches of the sensory radial nerve. We use the standard wrist arthroscopic equipment, 2.7 scope, 3 mm shaver, a radiofrequency probe, and a 3 mm burr. You can use the larger instruments, though it can become difficult to control, particularly the burr, with a much larger, faster oscillating burr. The surgical landmarks are gathered around the first compartment. I think it's best to think of the radial portal, the 1R portal, as being just very close and just next to the FCR tendon, just radial to the FCR tendon, and that actually is a bit onto the thenar eminence. And for the 1U portal, here we can see the 1R portal, which again is best placed just radial to the FCR tendon, hugging the FCR tendon, and the 1U portal, which is placed is hugging the first compartment, just dorsal, so to speak, to the first compartment by the EPB tendon. Here we can see, looking from the 1U portal, you can look over to the AOL ligament, and you can see how this is hugging the EPB. From the 1R, you can see the first compartment, but again, this portal I think is placed best right next to the FCR tendon. By placing this near the FCR tendon, there's less sword fighting, and you have your portals further away from each other, so they're more orthogonal and more orientated at 90 degrees. We reported on our initial results in the British Hand Journal with Dr. Adams, Sherry Merton, and essentially most of the patients, very similar to open suspension plasty studies such as the LRTI or the Wallaby. Most of the patients did very well, and I would have to say these results are not better than any open procedure, but in the same ballpark as far as clinical outcome. Here we can see an example of the beginning of the procedure. We can see on the left a needle being placed into the CMC joint under fluoroscopy to be sure we're not in the ST joint, which is very easy to confuse. Most beginners, I've noticed, tend to place the needle closer to the ST joint and are surprised with traction how far distal on the thumb is the true CMC joint. Once viewing is inside the joint, you see things such as loose bodies. You can look over to the AOL ligament. You can, of course, shrink the ligaments if you think that is a benefit. I usually use the radiofrequency probe mainly for debridement and visualizing the here we can see the progression of steps. On the top left is the arthritic step off of the trapezium. We can see in the bottom, after the shaver has created initial view, initial synovectomy, the burr is brought in. And then lastly, we can see the decorticated trapezium with cancellous bone that when the tourniquet is let down and interposition material is added, will provide a healing bed. Here we can see the standard setup in the operating room. It's helpful to have an assistant to stabilize the wrist and rotate it as you work with the viewing from, in this instance, from the 1U portal, and then after approximately half of the work is done and we've resected one half of the trapezium down to about 2 or 3 millimeters, then visualization is then switched to the 1R portal, and the burr and shaver are brought in through the 1U portal to complete the 2 or 3 millimeter resection of the trapezium. Here you can see a close-up the 1R portal, which again is hugging the FCR tendon, and the 1U portal, which is very close and hugging the first compartment. I think you would notice that the joint itself seems probably a little bit more distal than most people would think on the thumb. And I think this is partially due to the 5 to 8 pounds of traction that can confuse people and lead them to think that the CMC joint is more proximal than it really is. At the completion of debridement of the trapezium, when 2 to 3 millimeters of bone has been removed, then we add an interposition material. I've favored using a dermal allograft material, although others have used biodegradable polymers, and I don't think we have established what is the best material to use, but I've had very good success at using a dermal graft in this situation. The graft is itself pulled into the joint by placing a hemostat through the 1U portal, and the tip of the hemostat will then come out the 1R portal, and by grabbing a corner of the graft and also pushing and pulling, pushing with the pickups and pulling with the hemostat, the graft can then be brought into the joint and then spread out over the denuded trapezium. Here we can see an example of a patient pre-op and post-op. Pre-op we can see bone-on-bone arthritis, and post-op we can see the space that's filled with the interposed dermal graft. Here we can see an example in a 55-year-old gentleman with typical CMC arthritis, and then post-op we can see the space that's created by the interposed dermal graft and the slightly shortened trapezium by removing 2 to 3 millimeters of bone. Here we can see a 60-year-old gentleman, pre-op and post-op, and again restoration of a joint space after debridement and interposition. There have been a few comparison studies. This is a small study from Scandinavia with only 5 to 10 patients, but there are a few comparison studies. In this instance, a trapeziectomy and suspensionplasty was compared to a debridement and interposition with a polyurethane polymer, and the group with the spacer had better key pinch and grip strength. Again, although the numbers are small, this is one of the few comparison studies to simple resection. A study from Boston, a very similar technique to that we use at the Mayo Clinic, used a palmaris tendon graft, and also had excellent results and follow-up, very similar to the results that we've achieved. In summary, arthroscopic CMC debridement and interposition seems to be helpful for osteoarthritis of the thumb. But again, there are no true prospective studies done to date comparing to traditional open procedures. I would say that it's not better than suspensionplasty or LITI, but does not seem to be worse at this stage of follow-up. It does attempt to preserve the normal anatomy somewhat, and does not burn a bridge. If a patient has not done well from their arthroscopic technique, standard traditional open procedures can be performed. To date, I've had about 2 or 3 patients that I would think are failures, and one of those patients I did convert to a Walby suspensionplasty, and she's done well with that. Overall, I have noticed that patients sure do like the 2 small little holes as compared to the traditional open incisions. Thank you very much.